India registers 3.6 lakh COVID cases, 3,700 deaths in the last 24 hours. Vaccinations dipped drastically on Sunday, less than 7 lakh doses administered. The Government of India says the double mutation or the B1617 variant can be linked to the surge in cases in certain states. The World Health Organization says it is a variant of concern. And after the massive spike in cases, a 2-week lockdown in Karnataka and Tamil Nadu comes into force from today. Delhi and Haryana extend their lockdown till the 17th of May. Delhi suspends metro services. Hello and welcome to another edition of Coronavirus Facts versus Myth. Amid this sharp rise in COVID-19 cases, we continue on a daily basis to learn about new symptoms, side effects and infections. On the show today, we'll talk about a fungal infection that is being observed in a number of COVID-19 patients recently. This is called mucormycosis or the black fungus. It's a fungal infection that's been found mainly in COVID-19 patients with uncontrolled diabetes or those patients who've had prolonged ICU stays. It's also being linked to excessive use or misuse of steroids. Now, the government says that there is no major outbreak in India at the moment, but the National COVID Task Force has issued an advisory. We'll get you the details. On the show today, we'll examine what is this new fungal infection, what are the symptoms that you need to watch out for, and how this infection can be managed. Well, joining us on the broadcast, we have Dr. Manish Munjal, Senior ENT Consultant from the Gangaram Hospital. Thanks so much, Dr. Munjal, for joining us. I want to begin by asking you, what is black fungus and how is it linked to COVID?
Yes, whenever a person is immunocompromised, as is in the case of a COVID infection, and especially more so if the person is diabetic, he's a renal transplant or a kidney transplant patient, and has been provided life-saving steroids, if I may say, in moderate to severe cases, these patients have some issues with their immunity levels going down drastically. And that is actually required in a way because you need to suppress the immune response of the body while when the body is answering the virus. And it's a new virus, so the body doesn't know how much to answer. And to suppress that response, you give these immunosuppressants. Unfortunately, it also gives a chance for these opportunistic infections, one of the deadliest being fungal infections, to breach through your defenses and go into these areas, and from the nose, mouth, it can this fungus can grow in and cause a very fast, rapidly developing gangrene. That's why it's called black fungus, because of the appearance, the leatherite appearance of the tissues that it tries to kill. It can go from there, involving the sinuses and then into the eyes, and unfortunately sometimes very rapidly into the brain through the blood vessels and nerves. Right. And then that is the time when we lose the battle with it.
All right. Dr. Munjal, how frequently are cases being detected at the moment? Do we have any idea on percentages?
Difficult to say, because we are having a lot of, thanks to the media, first of all, I must tell you that there is a lot of awareness in this wave about this fungus, but it's going to hit us more hard, no doubt about it. We have got mucor groups now amongst doctors. We are discussing cross cases, and it is going to hit us hard because the amount of steroids that are being given this time is crazy. It's phenomenal. The steroids are disappearing over the marketplaces, over chemist counters, and that tells you the volume of steroids that are being given for treating mucormycosis. Because of that, the fungus is hitting really hard and early. And even in COVID cases that have not gone home as yet, they are in hospitals. So I would say that the percentage is increasing rapidly and would continue to increase, because classically the cases of mucormycosis start coming after 15 to 20 days of immunosuppression. Okay. And that is usually the case. Right. So we are just not reaching that zone. Okay. And we have started seeing cases.
I also want to ask you, what happens when one contracts it? How can early detection take place, and can early detection actually, reduce the chances of mortality?
Absolutely. The earliest detection would probably require treatment, no doubt about it, but it could be done very well and very fast. And that is if you have any one side of the face giving you some weird feeling like a pain, a hard crust like a furuncle or a boil inside the nose, a crust, anything that bleeds like a crust. And then if you have, if you press both the fingers over deep over your cheeks into the bone, if there is a different sensation amongst both pain or numbness, and sometimes if there is a redness, unexplained redness in one of the eyes or some sort of swelling in that area, I think these are the symptoms which one should get alarmed on and at least see an eye or ENT doctor or even a general physician immediately so that we can, take action over it. Unfortunately, there are no oral antifungals for this kind of condition if it is, and one has to institute IV antifungal therapy is very fast. But initially, it can be treated very well with antifungal therapy alone, and some cases you will require surgery.
Okay, and at what point, doctor, do you know whether it can be treated with drugs or whether surgery is required?
So the black stage, the eschar stage, till that time that has not formed. The thing is fresh and reddened up, and you just see a little bit of thing. Sometimes we do get a CT scan of the nose or an MRI of the sinuses to see whether there is any thickening of the tissues inside or the eye or the eyeball. And if those things are looking benign, nothing has gone out of it, the symptoms are very early, we can start the fungal therapy and start getting the patient to a better situation.
How can it be prevented, if at all?
Good. You stay at home. If you are mild, you don't have to worry about it, right? It doesn't happen to people who are not on immunosuppression.
Okay.
It will only happen to people who are on immunosuppression mostly, or who are priorly immunosuppressed, like diabetics and the ones I told you. So these people, if especially they can wash their nose every day with commercially available nasal saline irrigations, or even a homemade boiled water, saline made just about the consistency or taste of a tear, our own tears. That's called isotonic saline. Those washes are extremely good. And sometimes just to let not the mucosa break, if you put a drop in of a homemade badam oil or a paraffin oil, that should be quite helpful in treating or preventing the mucosal break. Because if the mucosa breaks, then only the fungus grows in easily. That's the thing.
All right.
So
the other question is, does it happen only in COVID patients, this black fungus? Is it a typical COVID-19?
No, no way. It is there. It's been there with us for a long time.
Right.
Mucormycosis, there are thousands of papers on it. We had researchers
but you're
going
seeing
on for
a
last many
heightened
years.
number of cases because of COVID.
Absolutely. There will be surgeons who have never seen a case in their life, and now we are being flooded. That's definitely the case. So no denying it. And especially hospitals and doctors, they need to be very extra careful because, there is overcrowding of beds in COVID hospitals. And if you have immunocompromised patients lying next to each other, there is definitely lack of hygiene amongst the staff and all to treat them. So an extra amount of hygiene, we are definitely trying to promote that, because a patient who's lying on bed will have little to, help himself. In a house, you can, have multiple hands to help a patient, but not in a hospital. So extra hygiene.
It's very interesting because the COVID Task Force Advisory talks about sterile water and humidifiers that are being used in COVID-19 patients to give oxygen. So obviously hygiene is a very big issue. But we're also seeing in Gujarat, for instance, which is seeing a lot of cases of the black fungus right now in the country, they've made separate wards. What's the rationale of doing it? Is it contagious?
Well, it is contagious in the sense that contaminated hands can definitely take it to another patient. There's no doubt. It is not heavily aerosolized like a COVID virus, but it definitely can travel through if you have not washed your hands on one patient and touched the other patient, especially the skin part or the nose part, or contaminated catheters. So all these things, or even, they are sharing bathrooms. The patients are sharing bathrooms in hospitals, and contaminated brushes, tiles, all of them can transmit the infection. So we have to be extra careful on that.
All right. So perhaps separate wards or separating patients who are being diagnosed with this black fungus could in fact be an effective strategy. Do stay on with us, Dr. Munjal, because I want to shift our focus to why this is happening. It is happening because there is a huge surge in COVID-19 cases and deaths, of course, that are taking place in this second wave. Now, the government of India has acknowledged that the double mutation, or the B1617, is linked with the rise in cases in certain states in the last 1.5 months. The World Health Organization chief scientist Soumya Swaminathan has in fact said that a variant spreading in India is more contagious. She says that the B1617 is likely to be a variant of concern because it has some mutations which increase transmission and also potentially resistant to antibodies that are generated by either vaccination or by natural infection. What does this mean? What does this new variant mean for our fight against COVID? We have Dr. Sarman Singh, Senior Virologist and Director of the All India Institute of Medical Sciences in Bhopal, joining us. Thanks so much, Dr. Singh, for sparing the time and being with us. I want to ask you about this double mutation, or the B1617. Now, the government has acknowledged that this variant is linked with the surge in certain states in the last 1.5 months. When the World Health Organization calls this a variant of concern, how concerned should we be?
Yeah, you very rightly, Sitaji, you told that it is really a variant of concern, and we actually know of sure that it is highly contagious. It has two important mutations. That is, one is at the nucleotide number 452, and another one is 484. So these two mutants, they are making it very highly pathogenic, because the infective dose is also reduced, and the conformation of the spike protein, because these mutations are happening in RBD, receptor binding protein. So the proteins which are conformed in a way that the receptor, what we call ACE2. So these receptors and the virus, they adhere very strongly. But I want to make one strong point here, because what WHO and others are saying. We did some 50 samples in central India, and we sequenced, and out of these 50, 20 have been fully, bioinformatics and analysis has been done, whole genome sequence. You will be surprised. Siddhi and Riva, which are already, they are about 12-hour journey from Bhopal, and about 12 hours from all parts of Delhi also. So we have found that was exactly, to be very precise, on 8th of February. These samples were collected on 8th of February. So it is not 1.5 months, but it is long back, about 3 months. These samples we got from Siddhi in February, from Raisen, from Riva, and of course remaining Seor, Bhopal. So in central India, it reached, you can imagine, on 8th of February. So we can see that in India, it has already reached long back probably. And if we could have done the sequencing by that time, I think we could have controlled this, surge effectively.
What you're saying, Dr. Singh, is very important, because, of course, I mean, the government has said that the surge in the last 1.5 months can be attributed to the B1617. What you're saying is that the first traces of this were discovered in central India, in Madhya Pradesh, for instance, back in February. So had action been taken then to prevent the spread of this variant, are you trying to say that we would have not seen the kind of surge that we're seeing in India today?
Yeah, because, definitely this Siddhi district is very remote kind of district. So if we could reach by 8th of February, probably in January end or early days of the February, we could have taken very serious and very highly stringent actions, and we could have controlled the travel. Probably, I have been on all the whenever I am on any of the media, I have been saying the lockdown, the relaxation in the lockdown, and the free movement of the people, it became really problem. So what people were accusing earlier, that it was UK variant which came in India, this came in November probably.
Yes.
And we had our own mutant in January, February.
Two questions. One, of course, you're saying that, this has spread rapidly to rural India because you're also reporting these mutant cases from remote parts of central India. So that's an extremely worrying story. The second question that I have for you is, what the government has said in its latest briefing. On the 5th of May, the government has acknowledged that the UK variant is actually declining in terms of the number of cases, and it is this double mutation that is now increasing. Why is this happening?
Yeah, very important. So what in our data also, what we found that the UK variant was only in 15%. And in 45% of the central India samples we collected, it was Indian, double mutant. So that is very, very true. Now this 45% in Maharashtra, if you see, it has gone to more than 55%.
Yes.
So it is increasing. So you very rightly said, now UK variant has been taken over by the Indian variant.
Okay. So UK variant is declining, Indian variant cases or the B1671617 that we know it as is increasing. Last question to you about the variants. Do we know at the moment whether this double mutation or the B617, is it more dangerous? Does it cause more deaths? Do we know anything about that?
It is difficult to say, but because it can escape the immune system, theoretically, I presume so, theoretically. But there is no data, it has to be analyzed.
No, but Dr. Singh, when you say that it can escape the immune system, what you're essentially saying is what the WHO is also fearing, that it can escape your immunity that you have because of a past infection. So you could get potentially reinfected with the double mutation, and even vaccine immunity can be skipped. So will our vaccines work against this?
I doubt so. We have to develop our new vaccines, which are, capable to tackle these mutants.
Okay, so very important points that you're actually raising about this variant of concern, which now by the government's own acknowledgement is behind the surge that is being reported in India. There are just about 1,527 cases of this double mutation that have been detected, but don't go by that number because very, very minuscule percentage of positive cases are actually being sequenced to understand these mutant strains in the country. Extremely important, the points that you made, Dr. Singh. We're going to slip into a very short break, but both Dr. Munjal and Dr. Singh are going to continue to be live with us on the other side of this break, which is when we will answer all your questions on COVID. Dial us on the number flashing on your screens, and the expert doctors will answer your questions. Stay with us. Welcome back. You're watching Coronavirus Facts versus Myths. Dr. Manish Munjal and Dr. Sarman Singh continue to be live with us. Our first caller, Yash, is dialing in from Ghaziabad. Go ahead.
Yeah, hi doctor. My name is Yash, and my question is regarding how can we prevent the black fungus infection, and are steroids really a contributing factor? Because until now, we used to look at them as a life-saving drug in the treatment of COVID. So would you advise less use of steroids in the treatment to lower the risk of this infection?
Right. Dr. Munjal?
When the steroids start causing it, but the one thing I'm quite clear about information, and that is under no circumstances in mild cases should steroids be given. So first step, as you asked, is the misuse of steroid that is happening in mild cases. So do not please use steroids. This is for all physicians and for patients, for chemists, whoever. If you got a fever that's mild, it's getting broken up by paracetamol, you're getting mild viral symptoms, and if you want to be more sure and your doctor gets those inflammatory markers like CRP is a good marker, if that is not rising too hard, do not go on to steroids. I mean, that is the first step you can take in preventing an immunosuppression in a normal human being. The second thing is hygiene, as I mentioned. If you think that your nose is crusty, you have anything like a dryness of the nose setting in because of antibiotics, because of all the medicine, the viral infection, start the nasal washes with the saline solution, homemade or commercial available, a little few drops of paraffin oil or a home clean badam oil or mustard oil would be quite good in doing so. However, if you have started steroids, your physician must have an idea of what your sugar levels are. And if your sugar levels are shooting up and your patient is somebody who's getting dependent, not able to clean himself or herself, then hygiene becomes paramount of concern in such patients.
Right.
And if they are at home, you need to really keep them clean. That's the best thing that you can do to prevent mucormycosis. And of course, the symptoms that we told you. However, I mean, if the steroids continue, things continue, of course, there is a chance and one must look at it.
All right. Our next caller, Geeta, dialing in from Mumbai. Go ahead.
Yeah, hi, good afternoon. My question was about the second dose of Covishield. Now, given that UK allows the second dose to be, at a 12-week frequency and even Ontario a 16-week, given the vaccine shortage, my question is if we miss that 16 weeks altogether for the second dose, what does somebody do?
Dr. Singh, would you like to take that on? What if someone's missing the deadline or even an extended deadline for the second dose?
Yeah, up to 3 months it is okay, but if you have crossed even 3 months, then probably you can start afresh. That is the only probably possible, because usually this kind of skipping 3 months is very rare, because I have not come across any case, but definitely if you have crossed even 3 months deadline, the second dose, then probably it will be better that the first and vaccine has hardly any response, so probably you have to start again.
All right. Our next caller, Shubat, is dialing in from Delhi. Go ahead.
Hi, good afternoon, doctors. My question was in reference to the steroids that is given to patients. Should we rely on the doctors to make that call, or should we, as say that considering some of the things that we've heard now, or should we just rely on the doctor's basis how the person is reacting? Like is it okay to give or not okay, or should we look at some alternatives? So if you just give some guidance on this.
Dr. Munjal.
Absolutely. It's a H4 scheduled drug. Now, H4 scheduled drug means you should not buy it from the counter. The chemist is not authorized to give you a steroid on the counter. But the problem is that we are facing a catastrophe of unsubstantiated proportions, never before kind of thing. So everybody is trying to help, and you're getting steroids on just walking onto a chemist shop. But absolutely, I mean, do not start steroids. You don't know the dose, you don't know the body weight by the thing. Most people are underdosed. In fact, I'm not saying no to steroid, but people start with low doses, which are not only not useful, but they will promote immunosuppression. And what about kidney, renal status, kidneys, liver, all these? It can cause cataract in 31-year-old, 32-year-old people if you give that. And what about bone osteoporosis? We are just talking about mucormycosis, but there are so many diseases associated with steroid use. So one has to be very careful. Do talk to your doctor before starting.
Right. Dr. Singh, any advice from you on the use of steroids?
Yeah, I have been saying many times, because what Dr. Munjal is saying, we all experts have been saying that people these days, unfortunately, it is on the counter available and everybody goes, and sometimes even the patient they press her, steroid chahiye. So that kind of thing, it is sad passes from many times has been seen, and this is unfortunately it is happening, and it was bound to happen, because steroids, and particularly in diabetics, it is well known. It is about 50 years old textbook. We know that it is in diabetic patients, if you give the steroids without any doctor's medical supervision, this kind of things they do happen.
Right.
Yeah.
All right. While sometimes steroids may be necessary for COVID-19 patients to recover, I think this broadcast has been extremely important to understand the flip side of it as well, which is that they come with their fair share of side effects. They are harmful for your body in more ways than one. So you must absolutely
advise. That is the only thing.
Yes. So you must absolutely only take medication under the advisement, medical supervision of your doctor. I think that's really the bottom line of this conversation. Thank you, doctors, very much for sparing your time and being with us on this edition of Facts versus Myths. That's all the time we have. Till then, stay safe.